So what exactly is premenopause and how is it different from menopause?
So perimenopause is that time period averages about 4 years prior to menopause. So perimenopause is when you start to have a lot of fluctuations. So the definition of menopause is lack of a period for a full 12 months. So average age of the first period is about 10 or 10 and a half. Some can be earlier, like 9 or even earlier, but average age is about 10, 10 and a half. If there's a male with breast cancer in the family, that is significantly higher risk. So that is a bigger red flag. So we want to make sure everybody is tested.
What is the first thing someone should do after finding that they're pregnant?
If you have a positive pregnancy test, well, I would say 2 things. One is to start a prenatal vitamin, but the other one would be to call your doctor to get an OB appointment. And if you don't have an OB, then to call around and get an OB appointment.
Welcome to our podcast. Today we have an interesting topic, different than real estate that I've been talking about today. It's about all the women that are out there, anywhere from teenagers starting periods to pregnancy to premenopausal. All the questions I've gathered from my viewers to ask our expert right here, OBGYN. She's going to be coming on our podcast and telling us all the detailed information. So I can't wait to get started. Let's go. Okay, we have Dr. Rush right here, an expert OBGYN on women's healthcare. Thank you for coming on our podcast today.
Thank you so much for having me.
Of course. Let's get a little bit of a background about yourself.
Yeah, so I went to undergrad at Texas A&M, went to medical school at Texas A&M as well, and then residency for OBGYN was up in Methodist, Dallas. And then I started my own private practice here in the North Austin area in Cedar Park. What? In 2009.
Oh my goodness. Yeah. So what made you lean towards the women's side?
I think I've always been attracted to more of the female care aspect, but I loved the fact that I had patients and relationships with patients, but also had procedures and surgery as well. So it's not the same day in, day out with a patient all day long. I get to do procedures, I get to do surgeries, I get to deliver babies. So you get to do a little bit of everything, but you also get to develop relationships with patients throughout their lifetime when they're teenagers and they need birth control or they're having period issues, all the way through to when they're having babies, all the way through perimenopause, menopause, everything. So it's nice to have that relationship with them for a long time.
That's perfect that you mentioned because that's what we're going to be talking about from beginning to premenopause. And a random question is, I'm sure you delivered babies, but do they come back to you once they're teenagers? And have you seen that?
I actually have. You mean as in the baby I delivered?
Yeah, I don't know if that's come up yet because I don't know how long you've been in the practice.
It has. So I've been here for 16 years. So that is just long enough to have some of those patients starting to come back. And so I have just started to see those in the past year or so. And it makes me feel a little old, but it's been great. I know it's kind of, you hit that milestone when, you've delivered that baby and that baby is now old enough to now come and see me as a patient. And now we're dealing with periods and birth control and we've crossed that bridge.
That's amazing.
Yeah.
You're an expert already.
Yeah.
So let's talk about the girls, I guess, right? At what age do most girls get their first period and what should they expect when it happens?
So average age of the first period is about 10 or 10 and a half. Some can be earlier, like 9 or even earlier, but average age is about 10, 10 and a half. The period can come on strong, just like a normal period, and be regular from there on out. Or sometimes it just is a little bit of spotting and then nothing for a few months until it comes back until you have another period. But it's a little unpredictable for everybody. But it's usually just at age 10, 10 and a half is the most common age we see it at, but it's a little unpredictable, but it can be anything. It can be light or heavy.
And then it's normal for them to probably miss a month or 2 here and there.
Yes, the first 2 years is the most unpredictable time. So the first 2 years can be irregular or heavier. So sometimes we monitor the first couple of years. If they come in to see me, if they're a little irregular, we say give it a little more time, unless they're just not having them at all, where they had a few and then they've gone 6 months, a year with nothing, then we kind of might check it out or work it up. But it's very common for the first 2 years to be very irregular.
I see. So I know for the girls, they see the pediatrician up to what, like age 16? Is that right?
I'm sorry.
The pediatrician, they would come to you guys after.
Yes.
So is it better for them to come see an OBGYN once they start a period?
The
Or not
pediatricians
necessarily?
can usually see them fairly
Okay.
well. We recommend pap smear starting at age 21.
I see.
So technically, we don't have to see anybody until age 21. However, we see them quite often for abnormal periods, if they're very heavy, if they're very painful, very irregular, if they have a breast issue, if they need birth control, all sorts of issues. So they do get referred to us for some of those issues, or if they have, abnormal discharge or itching or something that is not able to be treated by their pediatrician, they'll send them over to us.
Oh, perfect.
Yeah.
Perfect. And then leading to the birth control, you said, now can they use it for different things versus birth control?
Absolutely. That's probably the most common thing we use it for in patients is not birth control. So in the younger teens anyway, acne, mood swings, we'll use it for period control. If they're heavy, irregular, painful, it can regulate the cycles as well. So we quite often use them for regulation of their periods more than birth control in their younger teen ages. But definitely for birth control itself. So if they are sexually active, we say, hey, you get a twofer. It helps prevent pregnancy, but it also helps with your periods. It helps make them shorter, lighter, and less painful, and more regular and predictable. So we use them quite often for a lot of other things. There's a few that are specifically FDA approved for acne, and some that are actually FDA approved for heavy periods themselves.
Got it. Because I know when they start the periods, it's like they get a lot more acne that I've seen.
From the hormones.
It's from the hormone that I see, especially my girls reaching into the teenager.
Yeah.
And I don't know what this generation is. They're all like, they need to get rid of the acne as fast as they can.
Yeah.
So you said what age is comfortable for that, to take that for acne?
Any age
Okay.
technically is good for birth control pills.
Okay.
There are specific medical conditions that may be contraindicated for birth control pills, but that can be started at any age. It doesn't change fertility outcomes or worries in the future. And you don't have to be on it long term. So I tell patients and parents that if they want to be on something temporarily for a few months just to clear something up or just to help fix a current problem to see if it resolves after they've come off of it, just be on it for a few months, try coming off of it, see if it helps. They can stay on it longer if they prefer it. But sometimes it's just a temporary medication. Yeah.
That works pretty well for acne. To use that. That's awesome. Now, when they're coming for their first visit to see an OBGYN, what should a girl expect?
So it depends on what they're coming for.
Okay.
So if they're coming for their first pap smear, then we would do a general exam where we listen to the heart and lungs. We feel their thyroid. We'll do a breast exam, show them how to do breast exams if they don't know or uncomfortable with it. We'll also do a pelvic exam where we actually look at the cervix, feel the uterus and ovaries, kind of look around and collect that pap smear, which is cervical cancer screening. So that's what I would expect at the very first actual GYN pap smear at 21. We also talk about potentials of STI risks or birth control refills or any other medication refills they may need, any other risk factors that could be in their lives, like any sort of abuse or those types of issues. We would, screen patients for any of those as well.
That's perfect. And then when you're, as a parent, I'm sure they're asking, they've got on their periods, they're learning that safe sex, in school. But as a parent, do you recommend, when should that talk be?
I would say as early on as possible. Yeah. They're exposed to so much more these days with social media and just media in general, TV shows, games, even their video games. There's so much more exposure that I'd say the sooner, the better. Some schools and education, can educate them on that, and some don't do a very good job at all. So it's sometimes up to the parents to make sure that they're well informed, because you never know what you're gonna get.
Yeah, because I don't know what is being taught in schools. I'm sure there is. Pediatrician's office, there's there, but I feel like as a parent, it's an important talk once they reach that age. So
definitely important.
Now we're going to be moving towards, actually, we have one more question on that. So what would you recommend to a young woman who has been diagnosed with PCOS and wants to get pregnant in the future?
So PCOS, or polycystic ovarian syndrome, is kind of a hormone imbalance disorder. And there are different variations of it. Some have extra testosterone, some are overweight, or they may have insulin resistance, not necessarily diabetes, but a component of that or early forms of it. So it depends on to what degree of PCOS they have. The difficulty with PCOS and fertility is that they are having very spaced out periods and ovulatory cycles. So if they're not ovulating in a timely fashion, like every month, then it's hard to get pregnant because you want that chance each month to get pregnant. So if they're very spaced out, if their periods are spaced out every 6 months or 4 months or even once a year, then the odds of getting pregnant are very slim because you're not ovulating in a monthly fashion. So you want to kind of increase those odds for those patients. So we do have medications to kind of help with ovulation, but sometimes certain things, just like weight loss, can help with ovulation itself. Sometimes medication like metformin or some diabetic medications can help with the insulin resistance and help with ovulatory function. So it just depends on which issues they're actually having, but definitely can kind of evaluate those patients and give them medications and try to help hone in on when they're ovulating and help with the timing of ovulation as well.
I see. So it's not necessarily like they should start planning a young versus waiting later.
Right.
Right.
Yeah. So it's more about when they're ready to start trying and then where they are in that world of PCOS and what can we do to help them and help them ovulate. So, there are fertility specialists as well, and that's all they do all day long, and they're amazing at it. So sometimes patients just want to go straight to them so that they can be checked on every single day and get an ultrasound every day, lab work every day, just kind of checking into really hone in on how to conceive and increasing their odds as much as possible, whether it be with IUI or, IVF or anything like that.
I know. That's a whole other topic.
That's a whole different topic. Yep.
Next, we're going to be talking about pregnancy, right? What is the first thing someone should do after finding that they're pregnant?
If you have a positive pregnancy test, well, I would say 2 things. One is to start a prenatal vitamin, but the other one would be to call your doctor to get an OB appointment. And if you don't have an OB, then to call around and get an OB appointment. So you want to get that appointment as soon as possible because it may take a month or 2 to get in to see that doctor. So you want to make sure you call as soon as possible so that you can get in and you're not too far along in the pregnancy. You can check that pregnancy as soon as possible.
So as soon as you find out, just get that appointment.
Yeah. Yep.
And what are some of the major changes that happen to a woman's body during pregnancy?
There's quite a few changes that occur. So number 1, I would say the blood volume doubles. And a lot of people don't realize this, but the blood volume will double, which gives you a type of anemia, just because of its a dilutional effect. So anemia is very common, but the blood volume doubles. It's more of a protection when you deliver because everybody will lose blood no matter how they deliver. They will lose a portion of blood, and that doubling is a protective aspect. So when you lose that blood and after you deliver, you hemoconcentrate back up and then you go back to normal. So that's how women have survived childbirth for so many years. There are other things that change. The hormones will cause joint laxity. And so you can have pain in hips, knees, feet. Your foot size and your shoe size can actually increase each pregnancy or during a pregnancy just because your feet become more flat and that arch, you lose the arch support just because of the laxity. You can also have drier skin changes, the pigmentation of the skin. You can also have pelvis changes. So the pelvis will shift to accommodate the pregnancy. So back pain, neck pain, pelvic pain, pubic symphysis pain, all kinds of pain, just because that pelvis will shift to accommodate the pregnancy. So those are probably the biggest ones. Lungs, you have a shortness of breath of pregnancy, which is pretty common. Your vital capacity doesn't actually change, but because it becomes like squished during the pregnancy, your lungs will kind of expand outwards sideways to help compensate for that.
I remember it's like a flashback of my pregnancy when you're talking about this because I've had twins. So that's all I have.
Oh, gosh.
And all those things.
You've had all that too.
Yeah, type even 2. Swelling, my foot size took me several months to go back to what it was for a normal foot.
Swelling is also common too.
Yes.
Yeah. Water retention, especially in the hotter months, like in the summertime. Swelling's pretty terrible.
Yeah. So it's fun, but
Lots of changes.
Lots of changes.
Which is why it helps to have your OB and you're at your appointments to ask questions of like, well, I'm having this. Is it normal?
Yes.
And then we can say, yes, that's pretty common. And you have this or this sciatic pain. I mean, that comes with that pelvis shifting. So sciatic pain is pretty common. But if patients have never gone through it, they don't know what's normal and what's not. And that's why it's good to have your OB doctor to discuss it with, to know what's normal and what's not.
That was a pretty bad sciatic pain. I remember that.
Yeah.
Leading to our next question, why are prenatal checkups so important, even if everything seems to be going well?
It's a good question. Each visit, we check on multiple things. So we will check a fundal height to kind of see, is the size of the pregnancy appropriate or not? Is it on the smaller side, bigger side? Do we feel that there's a discrepancy? We also check the urine for protein or glucose to make sure that we're monitoring those. We also check your blood pressure, and we just check in on everything else. So, we would check in to see, are you having any problems? Are you having nausea? Are you having a weird pain? Sometimes you have itching, and you may think that itching on your palms or your soles may be normal, but it's actually possibly a concerning complication of pregnancy that we would work up called cholestasis of pregnancy. But you may not know that unless you're coming to your visits and talking to your doctor about certain problems. So we, check with patients. How are you feeling? Are you doing okay? Here's some tests that are coming up. We need to screen for this. We need to screen for that. We need to do ultrasounds, checking for genetic abnormalities or birth defects. We need to check on the size or checking on the position of the baby. Is the head up or down? Can you just show up and deliver vaginally in labor? Or do we need to plan a C-section or try to rotate the baby if the baby's breech? So it's important to come to the visits to make sure we're catching other problems that may be occurring.
Yeah. I mean, I've also had patients say that, we didn't know we were pregnant. We just went to the ER and then had some pain and they ended up having a baby. But that's a whole different story.
I know. I've had a couple of those and they're quite fascinating. Yeah.
Like how? But
I know.
So I guess what are some red flags during pregnancy that mean a woman should call her doctor right away?
I'd say any of the big ones that are probably pretty obvious, like any severe pains, any bleeding, fevers, decreased fetal movement from normal. Early on in the pregnant, you don't really feel the movement as much, but later in the pregnancy, you should. So if it feels decreased or abnormal in any way, leaking fluid, heavy bleeding, any of those, you definitely want to call the doctor or go to labor and delivery and be checked out.
Yeah. And then you guys are obviously educating them while they're having their visits, right? When you should be calling us for all these things.
Yeah.
Now let's talk about something different. I mean, cord blood banking.
Yeah.
Right. I remember seeing those a lot back in the day. I don't know why I'm not seeing as much anymore, but what is your thought on that?
So it's interesting. Back in the day, there was just cord blood banking, and now there's cord tissue banking as well as an option. Some are also banking full placentas. So it's evolving as we go, but they're still doing blood. There's different types of stem cells available in all those different tissues. And what they're able to do with those stem cells is a little bit different. Originally, just the cord blood, they could do certain blood issues like certain leukemias or sickle cell disorders. There's a long list, but with the different types of cells, so the cord tissue, if you save the actual tissue of the cord and send that off, there's more mesenchymal stem cells, and those can be used in other types of research, and they're using them for fascinating, research and like recreating certain organs, perhaps, and so the research is actually incredible. So, when it comes to cord blood banking or stem cell banking, it's kind of like a life insurance policy where you don't ever want to have to use it, but it's there in case you need it, right? So the research is actually pretty incredible, and it may be needed 50 years from now when the kiddo is older and has a heart attack, and they can regenerate some of that heart tissue, stroke. Some of those are using it for all kinds of issues now, and not just leukemias and some of those. So the research is actually pretty fascinating. You just don't know where it's going. But the only time you have to save those cells is at the delivery. Yeah. And so it's either you have that one chance to do it or you don't. There are some cord blood banks where it's public banking. It's just very, very expensive to be able to use those tissue and those stem cells. But it is kind of an interesting field, and there's so much research in it, and they come up with stuff almost every year. They're coming up with new research and new ideas and new ways to utilize those stem cells. So you just don't know where it's going to be in the future, to where what if your baby or your child grows up as an adult and needed that, but if they have a heart attack or a stroke or had an accident or something, and they could potentially use it in the future. It is kind of interesting where the research is going, but it's like a life insurance policy where you hope to never have to use it, but it is potentially there if you might need it. You can also do sibling matches as well. So some patients will save it for a sibling match to see if their sibling is a potential match that may already have an issue. So some do it for that too.
Yeah, I've had it for both the twins back then. I feel like everybody was doing back in the day, but I don't really see much right now.
Yeah.
But for those that have been it, probably just keep them as, as an insurance that you're saying.
Yeah, and it's not very expensive yearly to maintain. It's most expensive when you first bank it, because they have to do the processing and the freezing and the actual banking of it is the most expensive part of it. And then from there on, it's, the fees, $125
exactly.
a
That's
year.
what it is. Yeah.
But if you do blood and tissue, it might be double, that same fee per tissue that you're saving. But so it's not terrible to maintain it, but yeah, it's one of those things where it's just more of a cost.
A cost, safety thing if you really want to.
Right.
Do that.
Yeah, definitely not, it's an option. It's optional. I tell patients it's just optional. You don't have to do it, but I'd say if they look into the research of it, a lot of, patients are interested in it just because of the potential of it.
Exactly.
In the future.
What if?
Yep.
What does postpartum recovery really, what is that really, and how long does it typically take for each mom? I know it's different for everybody.
I know. I was like, man, that's a loaded
question. Vaginal C-section, right?
Yeah. I mean, recovery is always different for everybody. Typically, vaginal deliveries are going to be a much faster recovery than a C-section because a C-section is more of an operation and a surgery. But it is a little bit different for everybody. The bleeding after delivery is pretty common for both, called lochia. So the bleeding right after a delivery can last for days or weeks, or even all the way up until that 6-week appointment with your doctor. So that varies for everybody as well. Everybody has a different opinion on when they're going to get their old body back. Now, I will say it is never guaranteed to get your old body back, and that is not a guarantee ever. Some people can snap right back, and they're back in their little tiny pants before they even leave the hospital, and we're always very impressed, but it's not the norm. And that's what everybody envisions, or they see that on social media, like they just were wearing their little tiny skinny pants right before they left. But that is not the norm. I would say it takes months or even a year before you kind of feel back to normal. So it can take almost a year. Now, postpartum depression is a whole different topic, and that can last months, or up to a year. So, and that's hormone fluctuation, emotional swings, all of it. So, and that is definitely a thing. Baby blues, postpartum depression, very, very common. And that varies for everybody as well.
Yeah, I remember that even working at the unit and I came home and I was just crying. I'm like, I don't know why am I crying. I don't know if it's the hormones. But you feel it, like it's actually a thing.
It's
that
totally
people don't realize it.
And it's normal, but most people don't realize it's normal. Like it's not, I think people are embarrassed about it, and they are ashamed to talk about or say that they are crying or upset or not maybe bonding with the baby. And it's completely 100% fixable. Like we can help those patients. And so we just need to know who those patients are. So we have postpartum depression screenings that we can do in our office, or the pediatricians usually do them too. And if they pick up something that we don't have, they will send us a notification saying, hey, we got a postpartum depression screen score that is higher on this patient. You may need to see them sooner, and we'll call them and check on them sooner.
Yeah. So. And it's also done at some of the hospitals in postpartum units that they are doing the postpartum depression. They actually started doing a few years back because of that.
They did.
And just to see, do they need help? Do they need the social service before they're being discharged? Do they have everything? So
absolutely.
Very important. And especially for dads to also be there and support the moms in this phase. Yeah. Because I feel like
family support is crucial. Yeah. So to make sure that there's some sort of support at home for mom and for baby is very important. So we just like to make sure they have good support at home, because if they don't, it's even harder. Especially breastfeeding moms, it's really hard with breastfeeding because the lack of sleep is awful. And so combining that with everything else going on, it just makes it even worse. So having to get up every couple hours just to breastfeed and, sleep deprivation on top of everything else and the hormones and the emotional toll, it's gets worse.
Different.
Yeah.
But it's different in the culture, right? I have patients that are from, India or whatever, and they say that when they deliver afterwards, they're expected not to do anything, not even move, not even, their whole thing is to recover. Versus in the US, it's a different way, different recovery, I guess.
And I will say there are different cultures and different theories on how to recover postpartum. And some do have a lot more support than others, for sure.
So I feel like listen to your body, take it, as it goes. And then
definitely call your doctor if you're having any issues. You can always see patients sooner. Yeah.
Yes. With breastfeeding, get help if you need it with lactation.
Oh yeah, they're amazing.
Yes. And they come home, so get that help if you need it. And also, I think covers by a lot of insurance too. So
yes, a lot of them are covered by insurance. So if they see their lactation consultant, they can do virtual in-home consultations or even go to them. So there's a lot of options nowadays, which is good.
Yeah. And then another question is about mammograms. What are the rules on mammograms? What age? How often should a woman start?
We typically start at 40.
Okay.
But it can be sooner if there's a strong family history or genetic predisposition to it. So if there's BRCA testing that's positive, if you have a mother that was diagnosed at age 40, you would start at age 30. So we typically start 10 years prior to when the youngest family member was diagnosed. Or if completely low risks, normal risk, nobody in the family has breast cancer, we usually start at 40.
What if, you would expect a woman to have a breast cancer, but what if the male had it? Does that mean that a woman should also get it, like a father or somebody in the family?
If there's a male with breast cancer in the family, that is significantly higher risk. So that is a bigger red flag. So we want to make sure everybody is tested. So usually you want to test the person who actually has that cancer to kind of see if they have that gene mutation, because if they are positive, then that means there's a 50% chance of passing it on to others in the family below them, like their children. But that also means someone above them pass it to them, right?
Yeah.
Or it could be a spontaneous mutation, but you definitely want to test the family to figure out who has what mutation. If there's a male with a positive breast cancer, then you want to look at the whole family tree to figure out who all is positive, because there's probably more in the family that are also positive for that mutation, and they're all at increased risk for it.
Yeah, it's not talked about for males, but I've seen that. So
it definitely is possible, yes. And men don't expect it either.
No.
So they wouldn't understand or know what it was. So a lot of them don't think they could ever get it, but they have a little bit of breast tissue. And if they feel a lump, they definitely need to get it worked out, because it could potentially be breast cancer, and you want to work that up as soon as possible.
Yeah. Now we're going to go talk a little bit about premenopause. What exactly is premenopause, and how is it different from menopause?
So perimenopause is that time period averages about 4 years prior to menopause. So perimenopause is when you start to have a lot of fluctuations. So the definition of menopause is lack of a period for a full 12 months. And that's as difficult when you don't have a uterus, or if you have an ablation, or you're not having cycles. But that's the clinical definition. But basically it's when your ovaries finally kick out. So you're born with a certain number of eggs in your ovaries that you'll ever have your entire life. And once they all kick out, you are done. So once they stop dropping those eggs and you don't ovulate anymore, then you're officially menopausal. So once you go a full year with no periods, then you're officially there. But sometimes if you're not having cycles, say you had a hysterectomy and you don't have a uterus, but you still have your ovaries, you got to go off of clinical symptoms. But in that time frame, when they're kind of kicking in and out, when they're not as efficient, you're going to have a lot of fluctuations, especially with hormones. So, mood swings, hot flashes, night sweats, sleep disorders, fatigue, dry skin, vaginal dryness. I mean, there's a long list, and a lot of them are very vague symptoms to where you just don't know, is it this or is it something else? Am I just depressed because I'm depressed? And do I need an antidepressant? Or is it that I'm perimenopausal and I have all these other things? So we have a list in our office that we would have patients check a checklist of symptoms and have them just kind of go through it to see. And it's eye-opening to them, especially of like, oh, wow, I do have a lot of these things. Like maybe it is something related that's all together. Maybe it is perimenopause, or maybe it is hormones, and not just that I have depression, or not just that I can't sleep. But for sleep example, it may be difficult to sleep because maybe you're having hot flashes or night sweats, and that's what's causing the sleep disorder. Maybe you have sleep apnea. Maybe there's something else going on that's waking you up at night, or you have a kid that's coming in your room and it's disturbing your sleep. But, trying to tease out what's what. But if you have a lot of those symptoms, it could very well be perimenopause, which is the fluctuation of all those hormones leading into menopause, which is when they finally kick out, the ovaries aren't working anymore, the hormone level drops, so your estrogen drops off, and then you're menopausal from there on out. And then it's a totally different ballgame where you have increased risk factors for other things, like osteoporosis, because you have no more estrogen, so your bones can start to thin. You have to make sure you stay on top of calcium and exercise, and, or hormone therapy or hormone replacement therapy sometimes, if they're a candidate for it. So it just kind of depends on the patient and what their symptoms are and what they're looking for treatment or hormone therapy.
Wow, that's a lot of details right there.
I know. It was like, that's like, yeah, just perimenopause and menopause.
What age do you usually see perimenopausal usually starting, do you know?
So the average age of menopause is 51 and a half. So typically in your 40s is when we tend to see the most commonly. Now you can have it at the end of your 30s, early 40s. We can see a lot of symptoms where patients are just not feeling good, decreased libido. I would say that's a common fatigue. It's a big one. We see that quite often every single day in the office. But 40s is when we see it the most, sometimes early 50s. Some patients don't even go through menopause until late 50s. So I have some that are still having periods at 56.
Wow.
You just don't ever know. Everyone's a little bit different.
And is there a way to kind of like subside, minimize those symptoms of fatigue or this, or I don't know what that would be, basically. Any vitamins or make sure?
Sometimes, yeah. So we do have panels that we would run. So for example, for fatigue, that's one of my favorite ones because I'm like, so many things can cause it.
Yeah.
Is it your thyroid? Yeah. Is it anemia? Is it vitamin D deficiency? Is it B12 deficiency? Is it low testosterone? There's so many things that can cause fatigue that we want to check all of it because we want to rule all the other things out. So, and then we can kind of focus on where you're deficient. What can we do? What can we balance? What hormones can we balance? Where can we fix it? Right.
Yeah.
So then it's a little bit easier once we can check all the levels and see where everything's at and kind of see where we can go from there and come up with a treatment plan from there.
Wow. Okay. I guess the next question is, what can women do to stay healthy after menopause, especially when it comes to, like you said, bones health, and you're saying sleep. We just talked about that, but I want to say anything extra on that?
I would say definitely the bones are big. So you want to make sure you have weight-bearing exercises. So exercising, wearing a weighted vest is a really easy way for walking to help add extra weight onto the bones to help with that remodeling of it and help strengthen the bones. Calcium and vitamin D. So you need vitamin D to absorb the calcium. So that's why calcium typically comes with a vitamin D already included. So you want the calcium and vitamin D. Sleep is huge. You want to make sure you get enough sleep. So you want to make sure that you're sleeping well, increasing water, making sure you're drinking plenty of water through the day, balanced diet, obviously normal, dietary,
stuff that you should.
All the normal things, all the normal things that nobody wants to hear.
Yes.
But all the normal things. So, and then when it comes to hormone replacement therapy, I mean, it's a huge topic right now because I think it's just a hot topic in general because more people are talking about it these days. But hormones can help, health in general and longevity. So women are living longer these days. They're not dying in their 50s years and years ago, right? So after menopause, women didn't live much longer. So they didn't really have to live very long in menopause. But the longer that we're living, if we're living 80s, 90s, 100, we're living a long portion of our life in menopause, and you don't want to be miserable in menopause. You want to kind of extend that. You want to, it's about quality of life as well. So you want to make sure that you're, treating yourself properly. So you want to make sure you're getting everything tested, and hormones aren't bad. Your ovaries made hormones. Yeah. So hormones in generally are great. Yeah. So we're huge fans. Now some patients can't have them or it's contraindicated to it. So if you have an estrogen receptor positive breast cancer, we don't want to necessarily give you more estrogen and make it worse or increase the risk of recurrence, right? So there are some patients that we don't want to do it in. There are some contraindications to certain hormones. But if you're normal, low risk, sometimes just continuing on the hormones that your body naturally made a little bit longer can actually be very productive and like very healthy for patients. So most patients enjoy it. Most patients like it. They feel more balanced. They feel better. They're just kind of prolonging what they already had. So it just helps kind of carry them over and bridge them over into menopause a little bit smoother.
Oh, perfect. Perfect. Yeah. I know we talked about the hormone, but I had this specific question. Can you explain what bioidentical hormone replacement therapy is and who might benefit from it and for how long?
Yeah. So I will say, starting with the definition of bioidentical hormones, bioidentical just means that whatever you are taking is the exact compound that your body naturally makes. So when it comes, for example, estradiol, so your body naturally makes estradiol. So giving you estradiol is bioidentical. Now, bioidentical can come in different forms. There's a lot of prescriptions at the pharmacy that are bioidentical, that like a patch, an oral tablet, vaginal cream, certain topical creams. There are different forms of it that you can get that are prescription. You can also get things compounded as well that are bioidentical too. There are non-bioidentical options as well. And so those are other types of forms of hormones that are similar, where your body, those receptors still see it as estrogen, where estradiol connected to this receptor, but this other one may not be estradiol, but your body still sees it and acts like estradiol, so it can attach. It's just a little bit different. And so there's bioidentical just means that they're exactly the same compound that your body naturally made. So, but I'd say most patients feel better on bioidentical versus or other ones like conjugated estrogens. So I would say most feel better on the estradiol, but there's plenty of options for bioidentical type hormones. You can also get them compounded as well. So some patients like to compound it where we can tweak exactly different doses versus what's at the pharmacy is very, certain limitations to it. But we can compound certain creams or dissolvable tablets or injections or something like that that could potentially have certain amounts that you want. You can tweak it just a little bit each time. Wow. But there's different versions of it.
Yeah, again, if we need to get more detail into it, that's another topic we can talk about.
Another rabbit hole.
Exactly. But I feel like we've covered a lot from, starting your periods to menopausal.
Yeah.
Now we're at the end of our rapid fire. So just quick questions and answers. Cramps or mood swings? What do your patients complain about more?
I'd say probably cramps.
Cramps.
Yeah. When it comes to periods anyway, I'd say cramps. Yeah.
Yes. Pap smear or pelvic exam, which one gets more nervous looks?
Honestly, I would say most people think they're the same thing.
Yeah.
And so it all gets the same look. But pap smears are just the actual collection of the pap smear. But pelvic exams is just an exam looking down there. So, but I'd say most people feel that they're the same. So they correlate them as the same. If you say you need to do a pelvic exam, I think you're doing a pap smear. So I would say I get the same look no matter.
Oh, wow.
Okay. Yeah.
Maybe they don't know about it.
Yeah. I don't think
I was thinking it might be a pap smear because of,
the collection. Yeah. So, but yeah, so probably in that regard, I would say, probably the pap smear. But yeah, I'd say most of the time people think pap and pelvic exam are the same.
Yeah. It's like, what's going on? Okay. So what's one myth about women's health you wish you would disappear forever?
I would say probably the fact that you can be on your period for a pap smear.
Okay.
We have so many patients that cancel their well woman because they're on their period and it doesn't matter. It doesn't matter anymore. Okay. So, so many patients are worried about it or either they just don't want to come in on that, but we don't care. Nobody cares. But back in the day, we couldn't do them on a pap smear while you're on your period, but now we can. The technology has changed and it's a lot easier. So I would say that probably because we have so many cancellations because someone's on a pap smear, or if someone's on a period when they need to get their pap smear. Yeah.
Okay. So no need to cancel it.
No need to cancel it. Nobody cares. We don't care. You can still do it.
Yeah.
Yes.
What's something that you always tell your patients, even if they don't ask?
That's a tough one.
Yeah.
I don't know. This one, I don't know.
You don't know?
Oh, no, I don't know this one.
It could be like anything. It depends on the age of that patient.
It really depends on the age because I think it depends on the age and who's there.
Or what is. Yeah, what are they
if it's a pregnant patient versus somebody else. Because I do have spiels that I give everybody, and there are some things that I'll make sure everybody knows. But I think it depends on what they're there for.
Exactly. Yeah. Well, favorite part of being an OBGYN?
My patients.
Your patients.
It's got to be the patients. Yeah.
One word to describe childbirth.
Emotional.
Yes.
In a good or bad way. I think it could swing either way. But yeah, I'd say it's got to be emotional.
That's a good one, yes.
Mm-hmm.
A book, podcast, or show you recommend for better understanding women's health?
I'd say Mary Claire Haver's book, The New Menopause, is probably one of my favorite ones recently that I would say that's a really good one. I would also say, like for the men, the one I refer to the most and I recommend the most for men for pregnancy is probably, it's called Be Prepared. I think it's the handbook, a guide for new dads or something like that. That one's probably my favorite one for the dads that I'll refer them to. It's hilarious. It's amazing. It's funny. But it's absolutely true. And it's easier to remember and kind of learn about the process of pregnancy. So I'd say those are the probably the two I recommend the most or I like the most.
Okay. And if you weren't a doctor, what would you be instead? What would you be doing instead, I guess?
Maybe a travel blogger or something fun.
I can see you do that.
I love traveling. Yeah, I would totally maybe be a travel
just do that for fun too.
I know, right? I have a whole separate account for that. I know I just throw it into my usual daily, but I think it would be fun to be paid or make a living just traveling.
Yeah, and there's so many that do that now.
Yes. And I'm like, oh, how do you get to that? That'd be amazing.
Yeah.
But yeah, no, I love traveling. So like a travel blogger would be fun.
That would be cool.
Yeah.
Okay.
Be totally different than what I do now, but it's great.
Got one life, live it up, right?
Right? Yeah, for sure.
Anything else you want to add on?
No. I mean, I'd say it's definitely, I'd say the one thing people think if they either in menopause or if they've got a hysterectomy, they think they don't ever have to have exams anymore, or they think they don't have to go back to their OBGYN anymore. And I would say, no, that's incorrect. We see women all through all ages, all the way through. So, and if you've had a hysterectomy, you still need exams. We still look around down there. We still look at everything. Yeah. So I think that's another misconception is that some patients think, oh, I don't have a uterus. I don't need I don't have a cervix anymore. I don't need to go get pap smears, or I don't need to go back to my doctor. But you do. We still look at everything. We still check everything. We still do breast exams. If you have your ovaries, you still feel for the ovaries. You can get melanoma down there. So we still look in the vulva for melanomas. So we still look at everything. So you still got to come in. So we still want to see our patients.
Yes. So I really appreciate you being on our podcast and talking about all different stages of women's health.
Of course. I appreciate you having me. Thank you so much.
Thank you.